Good evening, everybody, and welcome to yet another session of our webinars in the Critical Care Forum. So we have crossed 175 webinars, and it's a very happy and proud moment. And today we have a very important topic in intensive care, that is seizures. So seizures, as you know, occur in various forms, various sizes, shapes. You can have a solitary seizure as a complication of a drug such as meropenem, imipenem, or levofloxacin. Seizures are associated with classic neurological diseases, encephalitis, meningitis. You can have seizures as a result of certain poisonings. Poisonings like organochloride have classic CNS manifestations and very refractory seizures. So it's very important, and occurrence of seizure increases the mortality in the ICU directly. It often leads to intubation and other kinds of problems. So we have a very nice speaker today, a very young and promising neurologist, Dr. JASMINE Parihar from All India Institute of Medical Sciences, New Delhi. She's associate professor there, and she is qualified also in neurology from All India Institute of Medical Sciences, and she has won some very nice awards also in a very brief career. So I think it'll be very interesting to hear from her, and she also has, I think, special interest in seizures, looking at her profile. So over to you, Dr. Jasmine, to take us through the next 45 minutes or so.
Good evening, everybody. Thank you for joining us on the Sunday evening. I am very delighted to be here, and I thank Dr. Tapesh and his team for inviting me for this talk, which is very important, not just for the neurologist, but also for the intensivist. And I see that most of the target audience here is intensivists. So I hope my slides are visible. Should I start?
Yes, please.
Okay, so first of all, about this backdrop, basically I'm showing targeted neuron, and the purple color here indicates the color of epilepsy. So Purple Day is celebrated as the Epilepsy Day. So that is why I have chosen this background. I have no disclosures, and I'll be briefly discussing this topic under the following headings, and I will try to answer your questions at the end. So basically, status epilepticus has been defined multiple times starting from 1970s. But here, the latest definition that seems to be most accepted is discussed here. According to this definition, which has been published by ILA in 2015, we have status epilepticus that is defined by two timelines, timeline T1 and timeline T2. So this timeline T1 and T2 are different for different types of seizures. Basically, timeline T1 is the one where we have continuous, where if the seizure activity is continuous, it is likely to progress into status epilepticus. So it is the timeline where it is impending status epilepticus. And the timeline 2, where if the seizure activity has crossed that timeline, it is bound to have a long-term neurological complications because of the ongoing neural injury, death, and because of the alteration of the neural networks. According to this timeline, the most dangerous form of status epilepticus, which is convulsive status epilepticus, also known as clonic status epilepticus, the timeline T1 is 5 minutes. That means, although the status epilepticus might not have caused damage, but 5 minutes is the time when you should consider it as impending status epilepticus, and if you do not take any action here, it is likely to progress to timeline T2, which is our target, that we do not want the patient to land up into timeline T2. So we have to take action before the timeline T1. So it is 5 minutes for convulsive status epilepticus, and T2 here is 30 minutes. And for focal status epilepticus, the T1 is 10 minutes and T2 is 60 minutes. However, for absent status epilepticus, we do not have much data, but the consensus statement says that the timeline T1 for absent status epilepticus is 15 minutes and T2 is unknown. So this data is based on the this data is based on the general duration of the seizures. Generally, the tonic-clonic seizures last for less than 5 minutes. So, and the focal seizure may last for up to 10 minutes. This has been seen in video EEG monitoring. So why is this timeline important? Because as the time progresses, there are a series of changes that take place in the brain that lead to increasing neuronal damage. So within seconds, there is protein phosphorylation, ion channel opening and closing, and excessive neurotransmitter release. Now, these changes, if not controlled, will lead to receptor trafficking, where there will be decrease in the inhibitory receptors and increase in the excitatory receptors. If still not controlled, it will lead to neuropeptide expression with increase of excitatory substance B and insufficient replacement of the inhibitory substance Y. And if the seizure activity is still allowed to continue or continue despite our efforts, in that case, it may lead to permanent damages to the brain because of the gene expression, DNA methylation, and regulation of the microRNA. So coming to the epidemiology. Unfortunately, we do not have epidemiological studies which address this issue in India, but we have many epidemiological studies from worldwide, and these studies come from developed as well as developing world, and we see that the incidence of this disease ranges from as low as 4.6 cases in 1,000 in a 100 population, from up to 46, I cannot see it, up to 41 cases per 1 lakh population. So the incidence of this disease also varies according to age. Like status epilepticus is known to occur more commonly in older age group compared to the younger age group. So in this epidemiological study, which was conducted worldwide, it has shown that not just the status epilepticus is high in older age group, but also the mortality related to this is also found to be high in the old age. Okay, so status epilepticus is not just the motor form of status epilepticus or the most dramatic form that people see. Basically, status epilepticus, as intensivists would know better, can be seen in convulsive phase as well as non-convulsive. So ILE has classified status epilepticus as status epilepticus with prominent motor symptoms and those without prominent motor symptoms. That without prominent motor symptoms is known as non-convulsive status epilepticus. Now, depending on the semiology of the seizures that the patient is having, it can be further classified as bilateral tonic-clonic, myoclonic, focal motor, tonic, or hyperkinetic. Out of this, the tonic-clonic seizure, tonic-clonic status epilepticus, is the most dangerous one, known as the convulsive status epilepticus, and most commonly encountered form also. Among the non-convulsive status epilepticus, that is the status epilepticus without prominent motor symptoms, it can also be seen following convulsive status epilepticus, and it may further be divided into patient in which the patient has a coma, or patient may not have coma. Like if the patient has coma, it is known to have a worse outcome, but in the patient who do not have coma, it is likely to have better outcome. In fact, the patient with status epilepticus without coma are known to be having moving non-convulsive status epilepticus, like they may be moving around, but they still are in the phase of status epilepticus. So now coming on to the stages. Basically, the stages of status epilepticus is actually the stages of evolution of status epilepticus. So these stages, according to ILE, have been divided into particularly 4 stages. First stage is early status epilepticus, where the patient has started having seizures but has not reached the time period to be classified as status epilepticus. For example, if the seizure is lasting for more than 5 minutes. So it is not exactly reaching the timeline where the patient is having status epilepticus, but the status epilepticus is impending, or it is a premonitory status epilepticus. Now, in such a patient, if we have given benzodiazepine as the first line treatment, if we have given Lorazepam or midazolam or diazepam, but still we are not able to control status epilepticus, In that case, we call this patient as benzodiazepine resistant status epilepticus. That means the patient is still seizuring, and we have given the first line of action, but the patient still goes on seizures. So that means the patient has now established status epilepticus. Now, after this, the next thing that we do is we give IV form of anti-seizure medication. Now, we will be discussing as we go along that what anti-seizure medicine to be used. But after the patient has been given one anti-seizure medicine, in addition to benzodiazepine, but the patient still keeps on seizuring. So that is when we call the patient as having refractory status epilepticus. So here we have to understand that in these three stages, that is early status epilepticus, established, and refractory status epilepticus, since we have already started the treatment, the time may not be very important. So the definitions do not count for time. What is more important here is that the patient has been refractory to the agents that we have given. Now, even after we have given these agents and the patient is seizuring and we have added one of the anesthetic agent, but despite that, the patient continues to seize for more than 24 hours after adding an anesthetic agent. That is when we call the patient as having super refractory status epilepticus. So the time in this definition, super refractory status epilepticus is one time-bound definition where the patient has to continue seizuring for more than 24 hours despite using an anesthetic agent. So in these, if the patient, despite being on anesthetic agent, continues to have seizures for more than 7 days, we call it prolonged super refractory status epilepticus. However, if the same patient has been going on having seizures for more than 7 days, but no anesthetic agent has been tried, either because the patient has not reached the hospital or because the patient has been at a facility where he could not be given that. So in these cases, we cannot, on the basis of just time, label the patient as super refractory or prolonged super refractory. We have to label the patient as prolonged refractory and not super refractory. So to call the patient super refractory, he has to be on anesthetic agent. So if the anesthetic agent is not used, we do not use the word super in that. So prolonged is time bound by 7 days. So there are multiple causes of status epilepticus, and every patient has to be evaluated for each of the cause. But whenever the patient presents to us, we should simultaneously be taking history. Maybe we are missing on something which is the primary cause of status epilepticus, and just giving anti-seizure medicine might not suffice. So treatment of the cause is equally important and very, very important, especially if they are reversible causes. So you have to ask for the good history in order to find out what is the cause of status epilepticus. So these causes can be divided into known causes, which can be acute, remote, or progressive. And then there are in acute, we have like stroke. And it is very important to understand that in elderly patient, stroke, the patient may not present with hemiparesis. They may only present with seizures or status epilepticus, especially in the elderly age group. So the status epilepticus can be the presenting feature of stroke. It could be because of intoxication, malaria, or encephalitis. In the remote causes, it may be a post-traumatic epilepsy where the patient might have had a silent period of many years or decades before presenting a status epilepticus. Or it can be a post-encephalitic sequelae patient, or it could be a post-stroke patient. And in these remote causes, there has to be a silent period before these causes these insults have happened to the brain. Otherwise, there could be progressive cause of status epilepticus, such as for diseases like brain tumors, and for progressive myoclonic epilepsies like Lafora disease, and also sometimes in patients with dementia, though it is rare. Then the patients with defined electroclinical syndromes. For example, we have patients with Rasmussen syndrome. So Rasmussen syndrome patients go on having focal status epilepticus for years to months together. So they are also classified under ILA according to the definitions under status epilepticus, though their severity may be different from that of convulsive status epilepticus. Then at times we may not be able to find the etiology, where we call as cryptogenic cause. So among all the causes that we have just mentioned, among the acute causes, stroke is known to be the most common cause of status epilepticus, whereas in the chronic causes, the patient who already has a history of epilepsy and has been taking anti-epileptic drug, but in the lower dose or has skipped the dose, that is the most common cause of chronic cause that leads to status epilepticus. However, the mortality is different. So mortality is highest in patients who have hypoxia or anoxia among the acute causes, whereas in the chronic causes, the mortality is high in case when the patient has tumors. So now we will briefly discuss about the management of status epilepticus. So in the management of status epilepticus, it is important to remember that time is brain, as we see in patients with stroke. So in status epilepticus, whenever we see a patient with status epilepticus, whatever, excuse me, just 1 minute. So we have to understand this, that the time is brain, similar to stroke in patients with status epilepticus. And when the patient has been found seizuring, it is very important that at times we may not know when is the patient seizuring. For example, if the patient has been found seizuring by the relatives in the bathroom, so whenever and they have last seen him well 1 hour back. So here the time to seizure onset is to be taken similar to as we see in stroke as the time last seen well. So whenever we are treating, what should be our treatment goals? So as in any emergency, establishment of A, B, and C should be our first goal, and we should be trying to stop the seizure activity and prevent the brain injury, and also to identify the cause simultaneously. So all these three have to go parallel, hand in hand, as we manage the patient. So for managing the patient, we can divide the course of management into patient who has been seen pre-hospital or out of hospital, the patient who has been seen in emergency department, or the patient who has been transferred from the emergency department to the ICU station. So we'll discuss all three of these. Now, the pre-hospital management is also equally important because we may be involved in development of guidelines, or we might just get a call from our paramedic staff that they have gone to get some patient and the patient is actively seizuring. So what should we give in such patients? So I'll come back to this chart. So basically in the pre-hospital management, again, our pre-hospital management team should be well versed with the acute stabilization of the patient, which is important. And according to the systematic review of 19 studies, it have been found that midazolam, which is given intranasal or in the buccal form. So basically, this study used non-IV form of midazolam and compared it with IV or IM form of diazepam. So it found that the buccal or intranasal form of midazolam, should be the preferred treatment in out-of-hospital setting because it is easy to manage, it is easy to administer, and it leads to better seizure control rate. However, rectal diazepam, which was historically used as the first non-IV drug in the emergency settings, it can be used if midazolam is not available. But nowadays, midazolam is most of the times available. But we also should consider the availability of the buccal or the intranasal form of midazolam, which is available in the form of sprays. So we should understand that once we have given the first line of management, in about 20 to 30% of the patients, the seizure still continues, and we might have to, and the team might have to bring the patient to the emergency, and the emergency transfer should happen. So these are the various doses that are to be given in the pre-hospital settings, which may be given by the paramedic staff. So, so here I wanted to emphasize that it is very important that the information transfer takes place well. So if you have already given midazolam and the patient has not improved, So waiting again and giving the midazolam again in the emergency department is going to waste our time. So it is important that what has been given, what information has been collected, must be transferred from the first team to the second team. So similarly, if the patient is going from the emergency team to the ICU team, the information transfer should happen at every point, maybe in the written format, in the documented form. So about the rest of this chart, we will be discussing this as we go. So now when the patient has been brought to the emergency department, again, we have to take care of the ABCs. We have to check the vitals. And additional, whenever we send the blood investigations in such patients, along with the routine blood investigations, we should immediately monitor the glucose level, even in the patients who are not on any therapy, who are not on diabetic therapy, should also get their blood glucose level monitored. Additionally, in elderly patients especially, monitoring of sodium is very important. And you should also send anti-epileptic drug levels, ABG levels. Maybe the patient is seizuring because of hypercarbia, for example, in patients who have COPD. And toxicology screen should also be sent, because if we have given a lot of benzodiazepines, then falsely the toxicology screen may come as high levels of benzodiazepines. So if the benzodiazepine has already been administered outside, that is fine. But if we have not, then your blood sample should also include a benzodiazepine in your toxicology screen. But waiting for this sample, you should not delay the administration of benzodiazepine as the first therapy. So if you feel that the seizure is going to last for long, you may also go for IV access, which may be in the form of central line. For some specific concentrations, when the patient is brought to you, if the patient is alcoholic, then you administer thiamine and glucose. It may just be status epilepticus because of alcohol withdrawal or because of hypoglycemia. And if the patient is diabetic, then you have to give glucose according to the blood sugar levels. And it is important that you get your neurologist. It is a multidisciplinary team effort. So you get your neurologist, your intensivist on board when you see a patient with status epilepticus. So here are the various doses that are used, that can be used. I will not be talking about each of the doses, but we should be informed, and maybe such charts can be put up in the emergency departments and in the ICU departments. So when the patient comes to the emergency department, we have to follow a certain protocol when we are administering the drug, and this protocol should be evidence-based. So generally in our hospital, we do not have any specific guidelines according to the Indian Epilepsy Society, but we are in the process of formulating those guidelines, or maybe expert opinions. We are in the process of formulating that. But till then, whatever is available, we are using the NICE guidelines. We are using the American Epilepsy Society guidelines. So according to these guidelines, we have divided the phases of management of patients in the emergency settings into 3 phases, or maybe 4 phases, and according to the stages that we had seen. So in the first stage, as we have discussed, that we have to stabilize the patient, look for the blood glucose levels, send all the screen. And if the patient is seizuring, then we have to give benzodiazepine as the first line of management. Depending on the availability, we can use intramuscular midazolam, or intravenous midazolam, or intravenous lorazepam, or intravenous diazepam. However, if any of these 3 are not available, what we can use is intravenous phenobarbital, intranasal midazolam, buccal midazolam, and rectal diazepam. But what does the evidence say? We have so many options, but what does the evidence say? So in this study that has been published in nejm in 1998, they compared 4 treatments for generalized convulsive status epilepticus for the phase 1 of management. So this is when the patient has been found seizuring, within what should be the first line of management. So they randomized 570 patients of generalized status epilepticus and gave them lorazepam, phenobarbital, phenytoin, and diazepam as the first drug. And this was followed by giving phenytoin in the long run, phenytoin as the infusion therapy. So what they found, that what was defined as the outcome was a successful treatment in which the patient has clinical as well as EEG resolution of the seizure activity within 20 minutes of initiation, without recurrence for at least 60 minutes after the therapy was initiated. So they found that the seizure control was best with lorazepam when they compared it with phenytoin as an initial agent. And also lorazepam was easy to administer, and it did not, as it could be administered in the bolus form and did not require an infusion form. So based on this trial, the recommendations have included lorazepam as first line of therapy in patients with convulsive status epilepticus. So once the patient has crossed the first line of drugs but has not responded, then we have to consider the second line of therapy. So second line of therapy, by the time the patient has been requiring second line of therapy and we have been performing the initial things, it may be up to 20 to 40 minutes. And in this, what we can use is we can use phosphenytoin, phenytoin, valproic acid, levetiracetam, or phenobarbital. So conventionally, by the time I was doing my internship or residency, MD residency, we would use phenytoin as the first line. At that time, levetiracetam was not widely available or widely known to be effective in status epilepticus. But now it is the nejm for all of us to use levetiracetam because of its easy availability. And it is having very less side effect compared to valproic acid or phenytoin or phosphenytoin. Additionally, levetiracetam can be continued as a maintenance therapy. So whatever you have given as an IV therapy may be continued as maintenance therapy. That is another reason that we are using levetiracetam. And one more reason that why we can use levetiracetam is that because a recent study has shown that levetiracetam may be given as a bolus within 5 minutes. So most of the infusions require, like, it may be given over half an hour or half an hour to 40 minutes. So but levetiracetam has been standard to be given over 15 minutes. But the recent study says that we can give that infusion of up to 4,500 milligram in up to 5 minutes also. So that is one more point in favor of levetiracetam. So let us see what the evidence says of what drug that we can use for the second line therapy in patients with status epilepticus. So here again, we have another beautiful nejm trial where they compared 3 drugs. They compared levetiracetam, phosphenytoin, and valproate in patients who were benzodiazepine resistant convulsive status epilepticus. So this is for the stage 2 where they have already received benzodiazepine and have not responded. So they found that among these drugs, the anti-seizure activity was good in all the 3, and it was equal, that they were able to control 50% of in 50% of the patients, these drugs were able to terminate the seizure activity within 60 minutes of administration. So all the 3 drugs, that is levetiracetam, phosphenytoin, and valproate, had equal efficacy. Also, both the 3 drugs had similar adverse events. So there is no preference. There is no preference according to efficacy in the 3 drugs, but definitely according to the side effect profile that we see, and especially in the long-term use, we may choose levetiracetam over other drugs. So if the patient has not got controlled even after giving the second line of therapy, then this patient has already entered into the phase which we call as refractory status epilepticus. So in such refractory status epilepticus, we have to either repeat the drugs that among the anti-seizure medicines that we have available. For example, if we have given levetiracetam in this patient, we may choose another drug with a different mechanism of action. That means that we may use phenytoin, or we may use valproate, or we may use lacosamide. And alternatively, we may also use anesthetic agent. But generally, as a clinical, since we do not have much evidence on this, what practically we use in our hospital, we at least try 2 anti-seizure medicines before we go on to anesthetic agent use. But once the patient has entered the refractory status epilepticus phase, it is important that we connect the patient to continuous EEG monitoring. This is important because it is likely that if the patient will have a refractory status epilepticus, even after the seizure activity, convulsive seizure activity may terminate, the non-convulsive seizure activity may continue. So we will not come to know whether the patient is in a comatose state because of the effect of the anesthetic agent, or he is in that state because of the non-convulsive seizure activity. So it is important. This is the time point where we should and we must order continuous EEG monitoring in all the patients who have reached the phase of or stage of refractory status epilepticus. So, so here is the proposed treatment protocol by the Korean Epilepsy Society, where again the same drugs that we have mentioned has been used for among the drugs for the anesthetic agents that we were talking about. The drugs that we can use is midazolam, propofol, thiopenton, or we could also use ketamine. So basically, all the drugs can be used, and there is no study to compare one drug over the other in status epilepticus with a good evidence. So we could use, in fact, we might have to use one over the other. At aiims, we have this practice of using midazolam, and if the patient is not controlled by midazolam, we go on adding ketamine, and then if the patient is not getting controlled by ketamine, then we follow to propofol or thiopenton or phenobarbital. So at times the patient may require 4 or 5 anti-seizure medicines. So now the point is that when should we stop? Like, what is the point where we stop? So there is no recommended point, like, that if you have added 3 anti-seizure medicines, better not to add 4 anti-seizure medicines. So we don't know. At times when we add perampanel to the drug of lists, which is to be given orally by crushing the medicine. But at times after adding that, the patient may improve, but we do not have a great evidence. So if there is an evidence only for the initial part of the status epilepticus, for the later part of the status epilepticus, which is associated with high mortality, we do not have much of evidence, especially for the anti-seizure medicines. So what becomes very important here, that we again look into the cause of the status epilepticus. For example, the cause in such case may be autoimmune encephalitis. So in such cases, in addition to the anti-seizure medicines that we are giving, it may be important that we also introduce immune therapy in this. For example, methylprednisolone or IVIG or plasma exchange. And there may be patients imaging is also equally important. So while we are stabilizing the patient in the first few hours, we may not be able to get the imaging, but if the patient is not getting controlled, we might have to order imaging in these patients to find out what is the reason. And we might also get our blood workups back by this time, which may also reveal the cause of status epilepticus. So here I would like to mention about one of our case where we had taken the history in a young patient. We were not able to find what is the cause. The imaging was normal. The EEG was normal. Blood investigations, the primary blood investigations that we got were normal. But by the evening, we were able to talk. The patient presented in the morning hours. By the evening, we were able to talk to the patient's mother, who told that he was a little depressed because of his weight. And he had, without prescription, started taking some medicine. So so we had asked them to get the medicine, and finally we found that the patient was taking 10 tablets of thyroxine every day, and his TSH value was 0.001. So it was thyrotoxicosis that had led to status epilepticus in this patient. And when it was managed by multidisciplinary approach by the endocrinologist, we had to discharge the patient in the walking state. So it is very important that we find out the cause and we treat the cause, and we take proper history when we are dealing with a patient with status epilepticus. So whenever you have such patients, what is the therapeutic target? So we have connected the patient to the EEG, and at times we may feel that we have to attain a burst suppression pattern. But generally, I have seen that our residents and us at times we are running after burst suppression pattern. But in convulsive status epilepticus, that is not what you target. You target to terminate the epileptic activity. You target to terminate the seizure activity. The seizure activity has stopped, and the EEG is not showing the epileptiform discharges. In that case, you may not go behind pushing more anti-seizure medicines or pushing more anesthetic agent to attain burst suppression pattern. However, if in the process of having the patient get termination of his seizure activity, if during that process our EEG has started showing burst suppression pattern, in that case we might have to maintain that pattern for a certain period of time, which may go up to 24 hours before tapering down the anti-seizure medicines. So if you have got, whenever we have started these infusions, what is the best time that we should, if the patient has got seizure activity controlled, what is the best time that we should start decreasing these medicines? So for this also, there are no definite guidelines when should we actually stop the infusion medicines. But what is generally preferred is that we maintain the patient in a seizure-free state for at least 24 hours before tapering down the drugs. So it is important, if the patient is on midazolam infusion or ketamine infusion, then you have to maintain the patient in a seizure-free state, and electrographically also, the patient should be electrographically also seizure-free for at least 24 hours before tapering down the medication. And the tapering should not happen suddenly, that it should go slowly. So depending on the patient's seizures, if patient had one failed trial of tapering the anti-seizure medicines, in that case, the further tapering when we give the next trial would go even more slow. What we generally do is that we give midazolam tapering at 1 milligram per kg or 1 ml per hour, and we slowly go and taper over 24 hours to 48 hours before stopping such infusions. So a little bit I will talk about non-convulsive status epilepticus. Basically, whenever a patient has status epilepticus and comes to you in a stage where the patient might not be having convulsions, but maybe in a drowsy state. So this is a common scenario where the patient is received in the ICU. The patient's seizure might have got convulsive phase, might have got controlled in the emergency. So we may think that the patient is currently having a drowsy phase or a post-ictal drowsiness, but it may still be a non-convulsive status epilepticus. So it is very important that we connect the EEG in such patients who are not gaining the consciousness back, or if we feel that the post-ictal state is longer than what is expected, which is generally up to half an hour. So if it is longer than what is expected, then we should connect the patient to EEG to find out if the patient is in non-convulsive status epilepticus phase. So basically, for diagnosing non-convulsive status epilepticus, we are now using the modified Salzburg criteria, where whenever we have a clinical suspicion of status epilepticus, basically, if we want to cut this short, there are two things that we should know. Patient, whenever we have suspicion of non-convulsive status epilepticus, we can give patient midazolam. And if with midazolam, the patient has clinical as well as improvement on EEG, then we label the patient as having definite status epilepticus. However, if one of these is present, then it is the patient is having a possible non-convulsive status epilepticus. So that is the general rule that we follow. But according to this criteria, whenever we see the patient who is having suspicion of non-convulsive status epilepticus, we will see the epileptiform discharges. If the frequency of epileptiform discharges is in the epileptic range, that is, the frequency of discharges is more than 2.5 hertz. And in that case, the epileptic activity is also there, and the patient, we are not now bothered much about the response to midazolam. If the frequency is more than 2.5 hertz, the patient is labeled as a case of non-convulsive status epilepticus, which may or may not be responding to midazolam. However, if the frequency is less than or equal to 2.5, but the patient has a typical spatiotemporal evolution. Spatiotemporal evolution means that the patient's EEG findings are evolving with time, and also from one section of the EEG, the findings or the epileptic activity has become more prominent and has evolved to other segments of the EEG also. So if the patient is having typical spatiotemporal evolution, then also even with the lower frequency, we can label the patient as having non-convulsive status epilepticus. If the patient is having subtle clinical ictal phenomena, for example, the patient is having subtle movements here and there. So that is also, even with the low frequency, but the patient is having subtle clinical phenomena, then also we can label the patient as having non-convulsive status epilepticus. However, if these features are not present, these subtle clinical features or this definite evolution is not present, but you can see that there is some change in the background, which may be just slowing, or which may be EEG discharges which are of less frequency. In that case, we have to give a trial of anti-epileptic drug. So if with the anti-epileptic drug, the patient has EEG as well as clinical improvement, so both these things should be present. If both these things are present, then we call the patient as having non-convulsive status epilepticus. However, if there is only EEG improvement, but the patient has not clinically improved, now this may be because the patient's non-convulsive status epilepticus is either refractory, or it may be because of the underlying condition. For example, if the patient is having meningitis, then his EEG findings are one thing, but his comatose state or his low GCS is not just because of the convulsion, it is also because of the meningitis that he is having. So in that case, the patient's clinical status may not improve after we have given anti-epileptic drug, but we have not yet started the patient on or the treatment of meningitis, or the treatment of meningitis has not yet started working. So in such cases, if the patient has the EEG findings, but the patient's EEG findings improve after giving an anti-epileptic drug, but the clinical status does not improve, in that case, we label the patient as having possible non-convulsive status epilepticus. Now, if the patient is not having any EEG findings, but he has some continuous rhythmic delta activity, that means EEG findings are not having epileptiform discharges, but the EEG finding shows slowness of the EEG, that the background is low. So background slowing can be of the delta or the theta range. So, but the frequency has to be more than 0.5 hertz. So if the patient is having a slow background and there may be fluctuations in the patient's EEG findings or patient's clinical status, in that case also we label the patient as having possible non-convulsive status epilepticus. However, if neither the EEG findings are present, nor the patient is having a clinical subtle phenomena, in that case, we do not label the patient as having non-convulsive status epilepticus. We have to look for other causes of decreased sensorium in such patients, which we may be missing. So a little bit about norse and fires. Norse, these are also commonly encountered phenomena now. Norse, these are again forms of status epilepticus. Norse is new onset refractory status epilepticus. Basically, this means that the patient is having first ever presentation of seizure as refractory status epilepticus. So it has been labeled as a different category. However, it remains integral part of what status epilepticus we have studied till now. And basically, what is different here is that it is a new onset and the patient never had a history of status epilepticus earlier. So here, there may be no pre-existing relevant neurological condition or active epilepsy. And also, we do not find any acute structural, metabolic, or toxic cause. So in such cases, we might have to try immunotherapy, as I'll be discussing. But however, the prognosis remains poor in most of the settings, but depends on the cause that we have. Now, what is fires? Fires is again a category which is classified under norse, where the patient also has fever in addition to refractory status epilepticus. So basically, this is febrile infection related epilepsy syndrome. Basically, it is a subcategory of norse and it may be found at any age. To label the patient as having fires, the patient should have a febrile infection that should be starting between 2 weeks and 24 hours before the onset. So if the patient is having fever when they presented with you, but there is no history of fevers in last 24 hours, so you do not label it as having fires. So the history of fevers should be at least 24 hours before the onset of the epileptic phase, before the onset of the seizure activity. And it may be up to 2 weeks prior to the seizure activity. Now we'll briefly, I'll mention about the role of immunotherapy. So basically, there is no high-class evidence to suggest that immunotherapy should be given in patients with status epilepticus. It is as in any other neurological condition. If you do not find any cause to status epilepticus, or you find a cause which is responsive to status to immunotherapy. For example, if you find an autoimmune disease in a patient who has status epilepticus, or you find autoimmune encephalitis antibody positivity, or you find some malignancy which is associated with autoimmune encephalitis, in that case, you may try immunotherapy. However, the role of immunotherapy in status epilepticus without any immunological basis is not. So this is the last part where we will discuss about the prognostic scores that are known in patients with status epilepticus. So whenever the patient comes to us, so there are two scores that are used in patients with status epilepticus. One, the most commonly used score is STES score. So as we can see, the STES scores just has the four parameters where the patient will be assessed for consciousness, first seizure type, age at which the patient is having seizures, status epilepticus, and any previous history of status seizures. So it is important that you know when should you do the test. For example, if the patient has come to you in the ICU, but the patient has received midazolam, so your level of consciousness should not be after the patient has received midazolam or is on midazolam infusion. So this is when the patient presents to the emergency. So at presentation, what is the consciousness level at presentation? So this score has to be used at the time of presentation. So if at presentation the patient is having generalized convulsive, so the score in the worst seizure type would be 1. If the patient has gone later into non-convulsive coma, then you do not label the patient as having score 2. So non-convulsive status epilepticus has come in the later part, but this scoring has to be done at presentation. So this is the test score. It is given a score of 0 to 6. The more the score, the worse is the outcome. And then there is a modification of this score, which is the modified test score, because they found that the age limit of 65 is a little less, and the age limit they had increased in this modified test score to 70, and they have added MRS scoring. So MRS scoring of the patient was added in the modified test score. The second scoring system is EMSC score, which is the epidemiology-based mortality in status epilepticus score. So as you can see in this figure, which I did not enlarge, that this is more extensive. And since you can see that the patient also has multiple other things that we have included, for example, we have included EEG in this, we have included the etiology in this. So these two things cannot be established at the time of presentation. This may be found as we go along treating the patient in the course of their illness. So this score is not necessarily to be done at the time of presentation. This may be done when the patient has been, when the cause or etiology has been established and the EEG findings have been established. The worst scoring of these is taken to mention the total score, and this score goes from 0 to 60. Again, the worst the score, the poorer is the outcome. So, according to this study done by Canditel in 2015, it was found that for prediction of in-hospital mortality, there was no difference between EMSC or STES. However, to determine the functional outcome, EMSC score was found to be significantly better. Now, this is the last section of this where we will talk about the role of surgery in status epilepticus. So this is a very recent systematic review which has been published where they have mentioned that what is the role of status epilepticus management, surgical management of status epilepticus. So basically, this review has incorporated 157 patients, but these patients are only from the case reports or case series. And as we know, if the systematic review is not to be considered as a high quality systematic review if it is based on case series and case reports. So here 157 patients were included where they underwent different forms of epilepsy surgeries, and such epilepsy surgeries, the most common form of epilepsy surgery that was done in the emergency setting was a focal resection. So that means that these surgical managements can be done in patients who are having a focal lesion. Otherwise, if the patient is not having focal lesion, then a detailed pre-surgical evaluation will be required, which may require time. But still, there have been case reports of improvement of the patients after the surgery, even in the patients who were non-lesional. So the take-home messages from this talk are, so time is brain. The earlier you start the intervention, the better it is for the patient. And you should promptly identify the cause to promptly identify that this is a seizure activity or this is a non-convulsive seizure activity or an effective intervention. And you should stabilize the patient and identify the cause simultaneously in parallel with giving the medications for stopping the status epilepticus. And the benzodiazepine should be started as early as possible. And your hospital, you should make all the efforts to equip your hospital for the pre-hospital treatment of status epilepticus. And there should be a lower threshold to escalate therapy. And continuous monitoring should be started, even if the convulsive phase has stopped, because there is a high chances of recurrence in cases of status epilepticus, and there are multiple complications because of the anti-seizure medicines that we give. And this is a multidisciplinary approach where we would require neurologist, interventionist, in which intensivist on board for the management. Thank you.
Thanks, Dr. Jasmine. So very nice talk and very useful. Please stop the sharing. So we'll take any questions from the audience if there are any. So meanwhile, Dr. Jasmine, I'll just ask you a couple of things which will be helpful. First of all, amongst the first-line benzodiazepines, when the patient is initially coming to you, should we go for Lorazepam or midazolam, or is there no difference?
So as I had discussed in my presentation, basically Lorazepam and midazolam, they have been tried, they have been studied in both pre-hospital settings and in the emergency department settings. And it have been found that Lorazepam is having superiority over others in early management of status epilepticus if it is given in the IV form. However, in the pre-hospital settings, if we are telling the person, then IV access may be difficult. So in that case, midazolam has been found to be a better drug where it can be given in the buccal form or it can be given in the intranasal form. So Lorazepam in the IV form and non-IV form, midazolam is going to be better. Okay. So this is according to the trial that published in the nejm. So there are a few trials. There are a few high-quality trials only for status epilepticus, and this is one.
Thank you. So the other question is about the newer drug, Lorazepam. So would you like to talk about it? It is coming into the picture, and Lorazepam is the go-to drug in the ICU for any kind of seizure, not only status. And now we have this Lorazepam. So any comments on the use of Lorazepam, your experience, and all you might be using a lot of it?
Yes. So first of all, levetiracetam has a longer market period than breveracetam. So any day we rely more on levetiracetam because it has been proven in a very high quality studies to be effective in status epilepticus. The trial that was published in nejm also have levetiracetam as one of the drugs when it compared with the valproate and phenobarbital. There are no as such high quality trials of breveracetam or comparing levetiracetam with breveracetam in status epilepticus. In my knowledge, there may be some, but I'm not aware of. But there is no high quality study that has come to my notice till now. And it is a newer drug, so I would always hesitate to rely on a newer drug when I already have available older drug which has been found to be more effective.
Thank you. So there are no questions so far. So I just like to make some points for the audience. So first of all, it's very important. Please calculate the dose on the basis of the weight and give the highest dose and give it in the give it rapidly. Don't delay it. Whatever guidelines are there, so such and such is the maximum dose and to be given over 5 minutes, 7 minutes, 10 minutes. Please give it rapidly at the maximum possible dose. In fact, studies have shown that when you give the benzodiazepine as the first drug, 30% of the patients only have adequate serum levels. So we are giving inadequate doses. It's very important. Secondly, even when you are giving the infusions, when you give the midazolam infusion, the propofol infusion, please start with the higher doses, and then you can always come down. The dosing is very important, and you have to give it rapidly. Then finally, she has talked about non-convulsive seizures. and one should have a high index of suspicion for unexplained altered sensorium being present in the ICU as non-convulsive status. It has been seen in studies that 10 to 20% of the patients with unexplained altered sensorium in the ICU at any time have non-convulsive status epilepticus. That's very important. Fourth point, please get an EEG done. Without EEG, you cannot manage status epilepticus. Because the patient is not getting up, it is very often due to non-convulsive status epilepticus going on after status epilepticus. Then be aware of the extra neurological complications. They can go into neurologic pulmonary edema, neurogenic pulmonary edema because of intense sympathetic discharge. Okay. Secondly, there is something known as SUDEP, SUDEP. These patients can have sudden cardiac arrest or sudden respiratory arrest also. So these things, extra neurological complications should also be known. And finally, there is something known as inhalational anesthetics. Isoflurane has been tried as an inhalational anesthetic, and it terminates the seizure activity in the super refractory cases in around 20 to 25% of the patients. And the special device, Anaconda device, which you have to inline attach to the ventilator and deliver the inhalational anesthetic. So if you have this, then this can also be tried. It is being used in certain centers. So those were the few points I just wanted to add to whatever the presentation, the nice presentation Dr. Jasmine has given us. And if there are I don't think any questions are there. So Dr. Jasmine, anything you want to say to the audience before we close?
Yes, you have very nicely highlighted the perspective from intensivist. One very important thing that you have said is underdosing. So we have mentioned the doses that we have to use, and it is a very common practice. The underdosing is very. There is a trial, there is a study also which mentions that 70% of the times we are underdosing the patient when managing status epilepticus. We have moved to the next drug, and we have not used the first drug in the highest possible dose. So levetiracetam people use only 2 grams. So the highest dose in adults goes up to 4,500. So basically, it is important that we use the maximum dose before labeling that the patient is refractory to this drug.
Yeah. Okay, I think there are no questions. The audience has understood everything and they have visited. It will be there on our YouTube channel in a few days' time. And people who have not joined can see it, and others can see it, and students can review it. So thanks so much, Dr. Jasmine. All the best. See you again sometime. Thank you very much. Bye-bye.
Thank you so much. Okay.